Good morning, good evening, or good afternoon, according to where you are attending our seminar today. Thank you so much for joining us, and it's my pleasure to introduce Dr. Chiara Pracconi. Dr. Pracconi is a consultant medical oncologist at the University of Glasgow, UK, and she developed a research platform on biliary tract cancer, connecting laboratory research and early clinical trial development, aiming to accelerate the predictive biomarker and therapeutic field. Dr. Pracconi will be the moderator for our seminar today. Welcome, Dr. Pracconi, and you can go ahead and present our guest speaker.
Thank you very much, Riham, and thank you, everyone. Thank you, the ICRN and the ESCA for inviting me. It's really a pleasure to be here today, especially given that I am with Sumera Ilyas, who will give a great presentation on the role of immune cells in cholangiocarcinoma. Sumera Ilyas is an assistant professor at the Mayo Clinic in Rochester, where she is a consultant hepatologist, but also leads a research group focused on immunobiology in cholangiocarcinoma. So today she will give an overview of what is the role of immunosuppressive myeloid cells in this tumor type. And we have decided to split the talk in 3 different sessions so that we can discuss various points that can come from her findings. So we will go from an introductory phase, and then she will discuss the mechanistic insights of the myeloid cells in the progression and the development of cholangiocarcinoma, and also the therapeutic implications. And then she will conclude with a discussion of the crosstalk between these cells and the rest of the microenvironmental cells. We really would like this session to be very interactive, so we are here to exchange ideas and share thoughts, so please feel free to send all the questions you want. There is a Q&A session at the bottom of the screen, and feed all the questions we would like to have them answered. And we will be very happy to answer these questions throughout the presentation. So, Sumera, now I will leave it to you, and thank you very much.
Thank you, Chiara, for that introduction, and thank you to ICRN and ENSDCA for the invitation to speak today. It's my pleasure to be here. So, as Dr. Pracconi indicated, we've sort of split the talk into 3 different sessions. So, in the first part, it's more general background information on immunosuppressive myeloid cells in the context of general tumor immunology. So we'll review tumor-associated macrophages, or TAMs, myeloid-derived suppressor cells, or MBSCs, and dendritic cells, or DCs. And then the second segment will focus on the mechanisms and therapeutic implications of these immunosuppressive myeloid cells, specifically in the context of cholangiocarcinoma. And so we'll review some of the studies that have been published, and then we'll finish off with the immunosuppressive myeloid cells in the context of CCA, TME, and crosstalk. So, as you're all well aware, cholangiocarcinomas, or CCAs, are very desmoplastic tumors. That they have a dense tumor immune microenvironment that you can see in this photomicrograph to your left. And this microenvironment has an abundance of immunosuppressive myeloid cells, such as TAMs. And we know that the response to immune checkpoint blockade monotherapy has been, in CCA specifically, has been subpar. And in the crosstalk of immunosuppressive myeloid cells, and in general, innate immune system and the adaptive immune system is not very well defined in CCA. And there are a number of potential therapeutic agents and targets that are under investigation, either at the discovery science phase or in early phase clinical trials. But to date, a regimen incorporating immunotherapy has not been approved in CCA. So let's start off with tumor-associated macrophages. So these are immunosuppressive myeloid cells, and in the context of tumor biology, macrophages in general can be pro-tumor or anti-tumor, but the preponderance of evidence suggests that they have a pro-tumor effect in aggregate. Macrophages are derived from bone marrow monocytes, and they can differentiate into tumor-associated macrophages, or TAMs, that are then recruited to the TME via cancer cell signals. And in the TME, there is extensive crosstalk between TAMs and other cell types in the tumor in the TME, and they play an instrumental role in development and progression of tumors by promoting cancer initiation and metastases via enhancement of angiogenesis, augmenting tumor cell migration and invasion, and suppressing tumor anti-tumor immunity. The chemokine CCL2 and colony stimulating factor 1, or CSF1, they augment TAM abundance within the tumor microenvironment. In the context of CCA specifically, correlative studies that have looked at TAM infiltration and abundance, they've demonstrated that an increased abundance of TAMs in CCA is associated with poor patient outcomes and resistance to, which include poor overall survival, as well as resistance to chemotherapy. In terms of resident liver macrophages known as Kupffer cells, Stuart Forbes and colleagues have demonstrated that resident liver Kupffer cells promote oncogenic transformation in CCA in a JNK dependent manner, and they did this using murine models of intrahepatic cholangiocarcinoma. So moving on to myeloid-derived suppressor cells, or MDSCs, these are a heterogeneous population of immature myeloid cells that are classified into two broad subsets. So there are granulocytic MDSCs, or GMDSCs, which are also known as polymorphonuclear, or PMN MDSCs. And in mice, these express CD11B, GR1, and are Ly6G high, and while being low in Ly6C. The other subset is monocytic, or MMDSCs, and in contrast to GMDSCs, in mice, they have high expression of Ly6C and low expression of Ly6G. MDSCs foster tumor growth, and they have a number of effects within the tumor microenvironment, including suppression of circulating of cytotoxic T cells, promotion of tumor cell proliferation and growth. And in human studies, we know that high levels of circulating MDSCs promote resistance to immune checkpoint inhibition, and that's been shown in a variety of malignancies, including melanoma. And as I mentioned, within the TME, MDSCs have myriad functions that support tumor growth by suppressing functions of cytotoxic cells such as CD8 T cells, NK cells, as well as dendritic cells, antigen-presenting cells such as dendritic cells, and they facilitate tumor cell proliferation and growth. Dendritic cells, these can be immunosuppressive in the context of tumor biology, but in general, these are antigen-presenting cells that present antigens to adaptive immune cells, and therefore would augment the anti-tumor immune response. But in the context of tumors, they can become dysfunctional or tolerogenic, and that's been shown in hepatocellular carcinoma, where studies have shown that a specific subset of DCs, known as LAM3 positive DCs, are dysfunctional, and they attenuate cytotoxic T cell function. An absence of functional DCs or presence of dysfunctional DCs is associated with poor patient outcomes in the context of cancer. And thereby restoring DC function, that would be a potential anti-tumor therapeutic strategy. So I think we'll pause here. Oh, Dr. Bocconi, Chiara, I think you're muted.
You're right. Sorry. Thank you, Sumera. Yes, while we are waiting for questions, maybe I can ask you something. I mean, you have talked about intrahepatic cholangiocarcinoma, and probably is one of the most studied of the old subtypes, because at least the background is a little more homogeneous and its delivery itself. So do we know if there are differences between the different subtypes? If we look at intrahepatic versus extrahepatic cholangiocarcinoma, are there any data about the different population of myeloid cells or microenvironmental cells?
I don't think there are any published studies that have looked at the different subtypes of the anatomic subtypes of cholangiocarcinoma, namely perihilar, distal, and intrahepatic, and looked at their differences in terms of their tumor immune microenvironments. There are ongoing studies, and we're actually doing work also to look at to profile the immune microenvironment of the different subtypes of cholangiocarcinoma. But our work is also unpublished as of yet. Some of the things that I can tell you from that work are that we've noticed that there's, an increase in certain types of cell populations in perihilar tumors and distal tumors. They tend to have a more similar tumor immune microenvironment compared to intrahepatic cholangiocarcinoma. So, for instance, we've noticed that there's more B cells and plasma cells in the perihilar tumors.
Yeah, probably I would agree with you that there is a big role for myeloid cells and tumor-associated macrophages anyway. I mean, we have done some studies in the past in a very small cohort of mixed biliary cancers where we looked at the transcriptomic of the peritumoral and tumoral area from an immune perspective. And, we could see that markers associated with macrophages like CD80 came up and was quite important from the prognosis. So I absolutely agree. What do we know about the differences between HCC and cholangiocarcinoma? Is there any difference there? Can we, is the background disease that might be more associated with HCC can create a shift there?
I think even there's a paucity of data, and primarily because we don't know that that the immune microenvironment of cholangiocarcinoma is less well defined than that of hepatocellular carcinoma, right? So there's been multiple different studies looking at the immune microenvironment of HCC. There's been a number of single cell RNA sequencing studies, and that's where we've learned things like, the dysfunctional dendritic cells, the LAM3 positive dendritic cells. And it's possible that subset, would also be present in cholangiocarcinoma, but that work just hasn't been done or published at least. And then, and even in terms of but I would say, I think I wouldn't be surprised if a lot of the same players are instrumental in both malignancies, right? Because if you look at the single cell RNA sequencing studies of HCC, we've learned that, that there are subsets of macrophages. There are subsets of macrophages that have more of an MBBS-like profile, and they're all very immunosuppressive. And so I wouldn't be surprised, but I think there's just a paucity of data to really have, a clear comparison and say that this is how the immune microenvironments of the two cancers differ.
Absolutely, I agree. And we have a question. What happens to the Kupffer cells in cholangiocarcinoma? Are there any data to suggest that only those near the tumor are activated, or there has been an activation of Kupffer cells all around, even far away from the tumor?
Yeah, so I showed one slide on the work that was done by, and that's probably the most elegant study that's been done looking at Kupffer cells and their role in cholangiocarcinoma. And that was Stuart Forbes's group that had shown that Kupffer cells themselves promote oncogenic transformation in CCA, and they do this in a JNK dependent manner. I'll show some data that we have as well. So I was very interested in Kupffer cells when we started really delving into the immunobiology of cholangiocarcinoma, and our hypothesis had been that Kupffer cells would actually play a significant role in CCA progression, because the liver is the largest reservoir of macrophages, and there's a lot of Kupffer cells in there. And so But the work, and I'll show this in a couple of slides, the work that we've shown, it actually showed that it's similar to other cancers. It's really the recruited macrophages that have more of a role in terms of promoting the cancer than the Kupffer cells. In terms of spatial distribution, it's a great question, you know, whether the ones that are closer play a more significant role than the ones that are in the adjacent liver. I can tell you from the work that we've done looking at adjacent liver and then completely normal baseline liver, we didn't find a lot of differences in terms of abundance, but we did find that the ones that are in the adjacent liver have more PD-L1 positive Kupffer cells, and then of course the tumors themselves have more PD-L1 positive Kupffer cells compared to the adjacent liver.
And can you just answer this question? I mean, you have talked about, you know, resident macrophages and interaction with the Kupffer cells. What do we know about the peripheral monocytes? Because we tend to think that, you know, they are not important until they get to the liver, and then they are under the exposure of a lot of factors from the tumor cells themselves. So, but you mentioned also that there might be circulating MBBS that actually impact. So what are your thoughts on peripheral monocytes?
I think peripheral monocytes are crucial in the context of tumors, because that's where all of these immunosuppressive myeloid populations are derived from. So we know that TAMs, not just in CCA, but in other malignancies, are primarily derived from circulating monocytes, right? So they're recruited to the tumor immune microenvironment by signals released by cancer cells, as well as other cells within the immune microenvironment, or general tumor microenvironment. And then MDSCs are immature myeloid cells that are also derived from circulating monocytes. So I think that population is very essential in tumor growth and metastasis.
Great, it would be very interesting to study. So maybe we can move on to the second part about you know, your mechanistic insights and therapeutic implication.
So in this part, I'll focus a lot on some of the studies, primarily discovery science studies that have been done in the context of cholangiocarcinoma, looking at the role of immunosuppressive myeloid cells, the mechanisms, as well as possible therapeutic implications that we can gather from these studies. So as you all are well aware, the presence of tumor cells leads to activation of cytotoxic T cells, and that promotes, in perfect world, tumor cell lysis. But cancers have a lot of cancer cells and tumors in general have a lot of mechanisms that can co-opt the immune system. And one of the well-known mechanisms is the induction of immune checkpoints. So in tumor biology, immune checkpoints such as programmed F1 or PD1 and its ligand, these are very important immune resistance mechanisms that limit T cell cytotoxicity. And it's important to remember that these checkpoints can be activated by cancer cells themselves, but also by host immune cells such as TAMs. And we know that CCAs have an abundance of TAMs, but their role within the CCA TME is just beginning to be defined. So I'll go over some of the work that we've done and others have done to look at these specific subsets in cholangiocarcinoma. So we recently demonstrated, and we published this work in a couple of years ago, that recruited PD-L1 positive TAMs that facilitate CCA progression. And we conducted these studies using a syngeneic orthotopic mouse model of CCA, which is driven by the oncogenes Ilyas-associated protein, or YAP, and AKT. And in this model, murine CCA cells that we refer to as SP cells are implanted in an orthotopic fashion into livers of mice. And we know that SP cells have abundant PD-L1 expression, but when we implanted them into PD-L1 knockout mice, there was a significant reduction in the tumor burden compared to wild-type mice, as you can see in this graph here. And these results suggested to us that it's really the PD-L1 positive host immune cells rather than PD-L1 positive cancer cells that facilitate CCA progression. And so then we took a deeper look into the different types of PD-L1 positive host immune cells, and we found that TAMs that are the predominant source of PD-L1 in both human as well as murine CCA. And in human CCA, as you can see to your left, we co-stain for PD-L1 and CD68, which is a macrophage marker, and PD-L1 and cytokeratin 19 or CK19, which is a CCA cell marker. And we did this in human resected CCA specimens, and we found that PD-L1 is expressed predominantly on TAMs rather than on cancer cells. And we also conducted flow cytometric analysis of murine CCA tumors, and which demonstrated that although PD-L1 is expressed on both MDSCs as well as dendritic cells, again, the predominant source was TAMs. And then we wanted to know whether these TAMs are resident Kupffer cells or they're recruited. And as I said, my initial hypothesis had been that it was the resident Kupffer cells. So it turned out that that was not correct. It's really the recruited macrophages that were the predominant population within the CCA, murine CCA tumors. And it is important to, you may ask, why does it matter whether they're resident or recruited? And that's because strategies for blocking these subsets are different. There are certain chemokine inhibitors that would be able to target recruited monocytes or macrophages, but not resident Kupffer cells. So, but interestingly, although our data had demonstrated that recruited TAMs are essential in CCA progression, when we implanted murine CCA cells into CCR2 knockout mice, so these are mice that are devoid of recruited macrophages, we found that they had a similar tumor burden compared to wild-type mice, which was surprising because we had felt that this was an essential population, and we anticipated a decrease in the tumor burden in the CCR2 knockout mice. So then we employed pharmacologic TAM inhibition using the inhibition of macrophage colony stimulating factor 1 receptor, or CSF1R. CSF1R is expressed by monocytes, and in tumor biology, activation of CSF1R induces a pro-tumor macrophage phenotype. But similar to our observations in the CCR2 knockout mice, we found that FR1 inhibition did not reduce growth in CCA growth in mice. So then we went on to profile both the CCR2 knockout mouse tumors as well as the anti-CSF1R treated tumors to see if there was a compensatory mechanism that was responsible for these findings. And interestingly, we observed that in both tumors, both the CCR2 knockout tumors as well as the anti-CSF1R treated tumors, there was an emergence of myeloid-derived suppressor cells, or MDSCs, and the preponderance of these MDSCs were Ly6G positive, indicating that these are granulocytic or GMDSCs. So then we went on to examine the potential mechanism, right? So how do these MDSCs emerge? Is there something within the TME that is recruiting them to the tumors? So we looked at the expression of various chemokines in both the control and anti-CSF1R treated tumors. We used an unbiased screen, and we found via this profiling that there was a significant upregulation of CXCL2 in the anti-CSF1R treated tumors. We then conducted fluorescence in situ hybridization, or FISH, and found that alpha smooth muscle actin positive cancer-associated fibroblasts, or CAFs, it was the CAFs that were the primary source of CXCL2 rather than the cancer cells in the anti-CSF1R treated tumors. And accordingly, the anti-CSF1R treated tumors also had an increased abundance of CAFs compared with vehicle treated tumors. Leading us to conclude that it's the CAFs that help recruit MDSCs to the CCA TME in the context of TAM blockade. So having demonstrated this compensatory emergence of GMDSCs, we then wondered whether inhibition of both TAMs as well as MDSCs would improve survival in murine CCA. We again employed our syngeneic model and carried out several therapeutic studies and employed anti-CSF1R for TAM inhibition, GMDSC inhibition using a neutralizing antibody against Ly6G, immune checkpoint blockade using anti-PD-1. And we found that dual inhibition of TAMs and GMDSCs led to augmentation of immune checkpoint inhibition with an enhancement of murine survival using this triple combination. You can see on the survival curve to your left, as well as the CT image on the right. And then since we had used a neutralizing antibody, we were wondering whether there was another way to inhibit MDSCs that may be more translatable. There's a recent study in Cell that was published by Sohail Tavozi and colleagues at Rockefeller, and they had demonstrated that liver X receptor or LXR agonist, GW3965, that is an MDSC inhibitor, and that increases apolipoprotein transcription, leading to MDSC apoptosis via the LRP8 receptor. And they also used and actually developed an LXR agonist that is currently in early phase clinical trials in several malignancies, which actually include cholangiocarcinoma. So we use GW as another way of inhibiting MDSCs, and as you can see on this graph to your right, when we blocked TAMs using anti-CSF1R and employed MDSC inhibition using the GW3965, that also resulted in a significant reduction in murine CCA burden along with immune checkpoint blockade, similar to what we had seen with the triple combination using anti-Ly6G. And further characterization of both the anti-Ly6G, anti-CSF1R, and anti-PD-1 treated mouse tumors, as well as the GW and anti-CSF1R, anti-PD-1 treated tumors, demonstrated a significant reduction in GMDSCs, as well as PD-L1 positive TAMs compared with control antibody treated tumors. And this alteration of the innate immune landscape of murine CCA tumors by combined TAM and MDSC inhibition with immune checkpoint inhibition resulted in a significant increase in CD8 T cell infiltration, as well as increased effector function, as demonstrated by an increase in granzyme B. So to conclude, in this manuscript, we had shown that PD-L1 positive TAMs are increased in abundance in CCA, and they promote exhaustion of CTLs and increased tumor progression. However, TAM inhibition promoted a compensatory emergence of GMDSCs, and dual inhibition of both the GMDSCs and TAMs that potentiated immune checkpoint blockade in murine CCA, with a consequent reduction in CCA tumor burden, as well as improvement in mouse survival. So to put this work in the context of other studies that have since been published, I would like to review the data from a recent study that was published in Gut. The investigators demonstrated, similar to our findings, that the CCA stroma has an abundance of myeloid cells, including TAMs and MDSCs, but it's with TAMs accounting for the preponderance of immunosuppressive cells within the CCA TME. And they showed this in a mouse model of CCA, and that mouse model was a KPPC model, and they demonstrated that there was overexpression of granulocyte macrophage colony stimulating factor, or GM-CSF, and accordingly GM-CSF neutralization decreased TAM abundance, as well as reduced CCA tumor burden in the KPPC model. So their working model is that TAMs are the predominant immunosuppressive cell type in CCA, and tumor-derived GM-CSF expression is prognostic in CCA. And accordingly, GM-CSF blockade restrains CCA tumor growth as well as TAM via reduction of TAM abundance, attenuation of inflammatory gene networks in tumors as well as in TAMs, and repolarization of immunosuppressive cells, including TAMs as well as MBSCs. So it's important to note that in this model, they did not see an emergence of GMDSC similar to what we had observed, which sort of speaks to perhaps the differences in the models that we had used. They had different, they were driven by different genetic mutations. This was another study that was published last year that examined the role of immunosuppressive myeloid cells in CCA. And this was from Tim Gretton's group. And they assessed the interplay between the gut microbiome, MDSCs, and CCA. And they demonstrated that gut barrier function is decreased in preclinical models of PSC and colitis. Then there's an increase in the chemokine CXCL1. And there is a TLR4 dependent increase in hepatic GMDSCs or PNMDSCs, which accelerated CCA growth in these preclinical models of both PSC and colitis. And that growth was attenuated by neutralizing CXCL1 as well as by using antibiotics, namely neomycin, or via hepatic TLR4 knockout. So all three approaches led to attenuation of CCA tumor growth in these preclinical models. And then in PSC patients, they assessed the levels of CD15 positive myeloid cells, which are the PMN MDSCs or GMDSCs in humans. They have a high expression of CD15. And so when they looked at PSC patients, they found that high levels of CD15 positive myeloid cells were present in patients who had active colitis compared to those who had quiescent colitis. This was another study that was published by Dr. Gretton's group, I believe it was also last year, and they investigated the role of CD40 agonism in murine CCA. So CD40 activates antigen-presenting cells, such as dendritic cells, and they demonstrated that CD40 agonism augmented the efficacy of immune checkpoint inhibition using anti-PD-1. There was increased activation of macrophages and dendritic cells, and which in turn led to increased activation of CD4 positive, CD8, as well as CD8 positive T cells and natural killer cells. They also assessed the triple combination of CD40, anti-PD-1, and gemcitabine, and found that this triple combination had enhanced anti-tumor activity compared to single agent or the combination of CD40 and immune checkpoint inhibition without gemcitabine.
Okay, so I think these data are extremely interesting, and I think that they do have a lot of clinical implications. So the first question that comes to my mind is, I mean, the data is about these compensatory mechanisms of the granulocyte-derived MDSC in mice, mainly treated with immune checkpoint inhibitors. And we know that actually you have used an LXR to try and inhibit this population, but we know the chemotherapy has kind of a great effect. Probably the granulocytes is the main population of the blood cells that is affected by chemotherapy. So could this be an explanation of the fact that in cholangiocarcinoma, the effect of monotherapy, immunotherapy on its own were not great, and probably we had to combine it with chemotherapy to really see some effect. We have seen the recent data from the durvalumab addition to cisplatin and gemcitabine that definitely are interesting and probably can change the clinical practice. So what are your thoughts about this? And if this might be true, should these probably inform how we need to combine the chemotherapy with the immunotherapy? Should we probably give it a start with immunotherapy and then kick chemotherapy later?
Yeah, so those are all really great points, and it's a great question. My personal bias is that I just, you know, which explains why immune checkpoint inhibition alone monotherapy has not worked in CCA, is that we really need to incorporate strategies. We really need to have strategies that incorporate targeting of not only the adaptive immune system, which is what immune checkpoint inhibition does, but also the innate immune system, and not ignore immunosuppressive myeloid cells. And so the million-dollar question is, what's the best approach, right? So is that combining immune checkpoint inhibition with chemotherapy? And you referred to, you know, some emerging data from the Topaz trial, and that had combined immune checkpoint inhibition with GemCis. Or do we directly target some of these immunosuppressive cell types and combine that with immune checkpoint inhibition, similar to the work that, you know, some of the preclinical work that I showed. And I don't know what the right answer is. I can tell you what my theories are. If I had to take a guess, I don't think that chemotherapy alone, or the usual regimens that we have with immune checkpoint inhibition, I think that there may be some improvement over chemotherapy alone, but I don't know if we will have some of the benefits that we've seen, let's say, in hepatocellular carcinoma, right, with combinations incorporating immune checkpoint inhibition. And it may be because some of the cytotoxic regimens, right, that incorporate gemcitabine or 5-fluorouracil, those drugs have been shown in certain studies to decrease or inhibit immunosuppressive cell types, including MDSCs, including TANs and Tregs. But we also know that they can decrease, that they target any proliferating cell types. So they can also target anti-tumor cell types such as CD8 T cells. And there was also some data, there was a paper published in the Journal of Immunology a few years back that had shown that after some time, gemcitabine actually promotes and leads to augmentation or increased infiltration of MDSCs in the tumor microenvironment. I think that was in the context of either breast cancer or pancreatic cancer. So I think I don't think we have a straightforward answer today. All I can say is that I do think that we'll need to have strategies that target both the adaptive as well as the innate immune cells and other elements. So we'll need a broader strategy, right? Which is why you're asking about chemotherapy, other elements being cells within the tumor microenvironment, like cancer-associated fibroblasts.
Yeah, and I think also we need to remember that the CD8, CD4 component is quite important. I mean, HCC, probably all the studies that have looked at the TIL in HCC and cholangio, they have seen that HCC is very rich of CD8 cells, and cholangio maybe is more rich in myeloid cells. So that probably is important. The fact also that the immunotherapy works in HCV positive HCC more than in NASH mediated HCC supports this fact. So I think it's important to really try and see which will be the patient's benefit. And my only concern with the Topaz trial is that the majority are still intrahepatic cholangiocarcinoma, and amongst that there is a small population of benefits. So if that is actually related to those patients who have a background liver disease, is something that needs to be dissected down when we will have the full data. So I absolutely agree. And you touched on another point that I guess is absolutely important about the importance of genomics, and we see this is having always a greater role in cholangiocarcinoma. And you've shown some of the data. I mean, how much should we really look into the effect of genomics into the innate immune response? Does it change the way that the microenvironment respond to the tumor and to the treatment?
I think that the data, the limited data that's there, it suggests that it does, right? And so that I showed this the two studies that had looked at TAM blockade. One was from my group, and then the other study was from the University of Rochester, and they had used a mouse model that was driven by KRAS, that was the KRAS P53 model, whereas we had looked at a YAP AKT driven model, and that was a primary difference. And they noticed that they had in TAM blockade alone was sufficient to augment immune checkpoint inhibition, and we did not have the same experience in our model. And the primary difference again was the oncogenes that were driving the tumors in these models. And we have, in my group, in my lab, we have profiled the KPPC model as well, looked at the immune microenvironment of that and compared it to the SB model, which is YAP AKT driven. And we found that the KPPC model is really a very monocytic model. So there are a lot of tumor-associated macrophages. There are, and there is an MDSC population, but that MDSC population is primarily monocytic MMDSCs. On the other hand, the SB immune profile has shown that they do have a significant proportion of GMDSCs. They have a lot of TAMs, but they have a significant proportion of GMDSCs. And so I do believe that the genomic landscape impacts the immune microenvironment and the abundance of various cell types and their interplay. And I think this is really, an interesting question that future studies should look to address. There's limited, there were a couple of studies at ASCO that had, ASCO last year, that had looked at the patients with certain driver mutations and looked at the immune microenvironment. And some of the key things that came out of that was, FGFR2 driven tumors had an increase in CD8 T cells. There were IDH mutant tumors had an increase in plasma cells and B cells. And so I think if we put the preclinical as well as some of the emerging clinical data together, absolutely the genomic landscape matters.
And I think with this, you also answer the question that we have from the audience about how does the mouse model's immune landscape compare to humans. And I think that you have already partly highlighted that there are some, analogies, but maybe we haven't completely understood which is the impact of the different genomics in the microenvironment in humans. So in some way, it's difficult to then compare to specific mouse models where we have selected alterations. Do you have any different thoughts?
Yeah, no, I completely agree. I think that it's something that we probably will be able to answer in the near future as an aggregate, scientific community that is interested in cholangiocarcinoma, because there are groups that are looking at in patients, as I indicated, with certain mutations and correlating that to the immune microenvironment. And on the discovery science side, I think it is really important. And Maya Alhambio from Mount Sinai always makes this point that the background of the mice really matters. So I think the more, and we're fortunate that we're starting to have more and more syngeneic models of CCA developing more of these models, and that will allow us to really directly compare and contrast the impact of certain driver mutations in human CCA tumors compared to mouse tumors.
Okay, thank you. Then we can move to the third part.
So moving on to the last segment of the talk. So this is really focused on TMA Crosstalk, and there's very limited information in the context of CCA, but I'm hopeful that in the near future we'll have more studies that have looked at the complex crosstalk in the CCA tumor microenvironment. So I showed this slide earlier where we had demonstrated that CAF-derived CXCL2 is increased in the context of TAM blockade and helps to recruit MDSCs to the immune microenvironment. There was another study that was published by a group in China last year, and that also examined the crosstalk between CAFs and MDSCs. These investigators had previously shown in 2016 that fibroblast activation protein, or FAP positive CAFs, recruit MDSCs to the CCA microenvironment via a STAT3 CCL2 mechanism. So in this more recent study published last year, they showed that CAFs potentiate CD3 positive MDSCs and enhance murine CCA stemness via hyperactivation of 5-glycoxygenase and its metabolites LTB4 and BLT2, and that BLT2 blockade enhanced efficacy of gemcitabine in a ICCA PDX model. The caveat of the study is that all the work was done in immunodeficient models, and we know that to really have an assessment of the CCA microenvironment, we need the immune compartment. So I'll sort of finish off with some work that we are currently conducting, examining the crosstalk between CCA cells and MDSCs. And this work has really centered on the role of tumor necrosis factor-related apoptosis-inducing ligand, or TRAIL, and its receptor, the TRAIL-TRAILR system in the CCA microenvironment. So what do we know about TRAIL? We know that TRAIL is a member of the TNF superfamily. It is a transmembrane protein and binds to its cognate receptors, leading to apoptotic cell death. And TRAIL is expressed on immune cells, and TRAIL receptors are upregulated on cancer cells. And these cancer cells are particularly sensitive to TRAIL-mediated cell death. So in light of this mechanistic basis, there had been historically significant interest in TRAIL agonism as an anti-cancer therapy because the TRAIL-TRAILR system causes CCA cell apoptosis. And there's an extensive body of literature on the anti-tumor role of TRAIL-TRAILR. However, all TRAIL agonists have universally failed in human clinical trials of a variety of malignancies. And so there is emerging evidence that suggests that TRAIL-TRAILR inhibits CD8 T cell activation and proliferation, may augment CD8 T cell death. But this has really been examined in the context of autoimmune diseases and not in the context of malignancy. So I'll show some data that we have. This will be all part of an upcoming manuscript that's currently under preparation, that looks at TRAIL-TRAILR and the MDSC CCA CD8 T cell crosstalk in the CCA TME. So before I show that work, the other background to remember about TRAIL-TRAILR, there are 4 human TRAIL receptors, two main receptors, TR4 as well as TR5, and then 2 decoy receptors. And so based on what we know from autoimmune diseases, we hypothesized that the TRAIL-TRAILR axis sort of has it's a double-edged sword, right? So yes, there is tumor cell death, but activation of this axis also has a pro-tumor role and can mediate immune evasion, either by decreasing the cytotoxic response or increasing the immunosuppressive elements within the microenvironment, or both, leading to tumor progression. And so to examine the role of TRAIL-R, we looked at TRAIL-R mice, and we did this actually using both our SP cells as well as the KRAS P53 cells that I had mentioned earlier. And we found that there's a significant reduction, as you can see, in the tumor burden of TRAIL-R mice that had knockout of the TRAIL receptor. Which was interesting to us, and so we profiled these mice and found that there was a decline, that the TRAIL-R knockout mice had a significant increase in reactive CD8 T cells, had an increase in reactive CTL function when we looked at granzyme B, but we didn't really find a direct effect on CD8 T cell apoptosis, which is something that had been shown, as I mentioned, in autoimmune diseases. And but there was an increase in proliferation. And so we've also looked at the effect on the myeloid compartment, TRAIL-R and its effect on the myeloid compartment. So based on that work, we found that TAMs are not significantly changed, but there is a reduction in both MDSCs as well as GMDSCs in the TRAIL-R knockout mice. And so these data were interesting, and then led us to look at CCA tumors in mice that had specific deletion of TRAIL on myeloid cells. So we used lysem-cree TRAIL-R flox mice and found that these mice had a significant reduction in the tumor burden. And when we profiled them, they had a decrease in both GMDSCs as well as monocytic MDSCs. And so we wanted to look at whether this was a direct effect of TRAIL-positive cancer cells on MDSCs. And so we looked at MDSC immunosuppressive function, proliferation, apoptosis, and found a significant decrease in PD-L1 positive MDSCs, as well as a decrease in MDSC proliferation. Indicating that perhaps there is a direct effect of TRAIL-R on MDSCs. And so our working model for this project is that the TRAIL-R axis mediates CCA tumor immune evasion via an immunosuppressive myeloid response. And some of the studies that we have ongoing are looking at the mechanistic basis of this, right? So why is MDSC proliferation increased? And then is there a direct effect on CTL? So as I indicated, we had seen that there was an increase in CTL proliferation. So a lot of this work is nearing completion, and hopefully we'll be able to share it with everyone in the near future. But part of the reason, we were interested in TRAIL-R, it goes back to the discussion, Chiara, that we had during our second segment, which is that it really will have to be an approach that targets multiple elements of the microenvironment, because we've seen that if you suppress one, another one emerges, right? And there's extensive immune evasion, and that really speaks to the clinical outcomes that we've seen in CCA. So I'll kind of finish off with our key takeaways, right? So I hope that from this work we've learned that immunosuppressive myeloid cells are a really important population. They're essential in facilitating CCA growth and progression. There is extensive crosstalk between immunosuppressive myeloid cells and other cell types within the CCA TME, and then combinatorial immunotherapeutic strategies that target elements of both innate and adaptive immune system are a promising approach. I'll finish off there.
Yeah, I mean, I absolutely agree with you about the fact that I think it's more and more, there is more and more evidence that we really do not need to target one single, pathway. And probably this has been also the biology behind the failure of the targeted therapies, generally. But and with respect to what you have presented about the loop between the CAF, the myeloid cells, and the cancer cells. We recently have some unpublished data, which is in pancreatic cancer, but actually shows how when we started to look at the transcriptomic of this tumor, looking at mainly stromal signatures. And we identified a group of tumors that were very rich in matrisome, probably more, kind of a CAF related. And then we inputted that into in silico drug discovery projects. We really saw that the perturbations that were able to reverse that signature was actually around the knot of CD40, which probably really, identifies this link about, the matrisome, the CAF, and the myeloid, and probably the cancer cells that you had suggested. So there is another question. Again, congratulating on your wonderful talk. Have you looked at peripheral blood myeloid cells in cholangiocarcinoma patients and where they also have the trail receptor?
Great question. So we're actually actively looking at that because it kind of goes back to this thing, right? That you can't just cure cancer in mice, and we really have to correlate a lot of what we find on the preclinical side with patients. So this is something that we're actually actively looking at. We have looked at trail on so not in peripheral, but in human CCA tumors. So we have single cell RNA sequencing data that has looked at that, and we've shown that MDSCs do express trail and the trail receptor, right? Because the hypothesis here is, so the traditional hypothesis that is the trail receptor on cancer cells that's activated by the ligand coming from immune cells that kills the cancer cells. So now we're looking at the other arm, which is that it's the receptor on immune cells, and it's the trail positive cancer cells that are activating this. And so yes, we have seen that MDSCs and also GMDSCs have the trail receptor in human CCA.
Okay, I think there are no more questions, and we are very close to the closing time. So thank you very much, Sumera. That was an absolutely interesting talk, and it was really a pleasure to be here. So Riham, I'll leave it to you.
Thank you so much, Dr. Precconi and Dr. Ilyas, and thank you for all our attendees. The seminar will be recorded and it will be available on the ICRN website. So thank you, and hope you all have a great weekend. Bye-bye.
Yes, everyone.
Bye-bye.
Bye.